Hi, this is Brian Kim. I'm going to share with you case number 276 in the Best Way to Do Cataract Surgery series. And the title of this series is not to suggest this is the best and only way, but to get you to think critically of your technique so that you can provide the very best for your patient. So this is I thought a routine cataract surgery. Then immediately I discovered this patient has severe zonulopathy and really total bag collapse. And so as a bag is collapsing, I'm having to find ways to take this lens out. And you're going to see mechanical fracturing being used to leverage those techniques so I can safely remove the lens, using capsule retractors to hook the peripheral bag to prevent total collapse of the bag as I'm trying to remove the last remaining pieces of the lens, and then converting to a Yamane technique in order to sclerofixate this lens in this situation where there is complete capsular bag collapse. You're going to see throughout this case, when I'm able to identify the zonular disease, what I'm able to do to continue throughout the case, and the thought process as I try to tackle this very complicated situation. So as you can see, this looks like a routine lens, routine case. This patient's being done under topical anesthesia. I use a corneal marker to help me center and size the rhexis using the cotton tip to control the eye. And then I make my paracentesis incision, first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. Nothing unusual so far. This is some intracameral epinephrine, and then some dispersive viscoelastic. And as I push with the dispersive viscoelastic, I do notice on the left side, the lens is pushed back more than the right side. And so immediately I'm like, that's a little weird, but I don't really overanalyze. I'm going to find and look for other cues that will validate my concern that the left side lens seemed to be pushed back more than the right side, again suggesting perhaps on the left side there's some zonular weakness. So this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. And these are the Moria microrhexis forceps. I puncture the center, pull down towards me, and I grab the right side of the tear. And as I do this, you can see there's some stria in the capsular bag right here. And so that's sign number 2. Maybe there's something going on with this lens and the bag. And then sign number 3, you can see as I'm pulling, there's loss of counter resistance and there's folds within the capsular bag. And I'm trying to pull and go across, but there's loss of resistance here. You see there's loss of resistance. And now my rhexis is a little bit smaller than I intended. Since there's loss of resistance, you can see that the rhexis is smaller than I intended. Again, why? Because as I'm pulling, that lack of resistance is causing the rhexis to become smaller. And now you can see here there's more stria. The rhexis is smaller on the left side. And again, this is the area of weakness that I was concerned about. I go ahead and finish off the rhexis. And this is the capsular fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, being very careful, lifting that lens up. And thankfully, the lens is fairly loose from the bag. You can see that left side of the lens is very loose. The right side is not so much. Gently using that cannula to try to loosen the lens up. But again, I'm not trying to rotate the lens. But as you see here, now you can see the edge of the capsular bag up and to the left there. So I can see the edge of the capsular bag. I know that that side is definitely weaker. Again, multiple phases of confirmation, 5 or 6 confirmations that the left side of the bag is really not very stable. I lift the incision with a chopper, go in with irrigation off to minimize Descemet's trauma. And right here, I'm asking my staff to lower the bottle height. And then I try to suck with the bevel down. You can see the lens just comes right up. Again, I'm very worried about loose zonules. You saw that right there. And so I was like about to chop, and I was like, you know what? I'm going to go ahead and do a sculpt. I'm not confident of this bag. So I go ahead and start sculpting. And as I start to sculpt, you can see the lens just tries to come up Again, I'm very, very worried about the zonules. Sculpting very slowly, but gingerly and carefully. And every time it pulls up like that, I just worry. So fortunately, the lens does spin, so I'm able to turn the lens and sculpt some more. I want to get a deep trough so I can fracture this lens in half. Do everything I can to my advantage in this context when the zonules are really bad. Placing the chopper under the rexus edge contra, incisionally perform a terminal chop, fracturing the lens from the terminal side, propagating that tear all the way through and through. Placing the chopper under the right heminucleus, hooking the peripheral lens, and fracturing the lens in half. Getting under that first quadrant, lifting it up with the phaco tip, and then using the chopper to mash the lens piece, lifting it up with some vacuum, and then emulsifying that first quadrant, crushing it between the instruments and emulsifying the lens piece. So first quadrant is out. You can see the lens is very wobbly. Every time there's sudden loss of resistance with the post-occlusion surge, you can see the lens just jerks. And that's because of that zonular weakness, the poor zonules, just weak zonules. It's not holding the lens and the bag taut. The zonules are supposed to keep the lens and the bag on stretch. But because of that sudden change in vacuum and the sudden negative pressure differential, it causes the whole thing to jerk around. Performing another cross-chop maneuver, fracturing that second quadrant in half, and then using some vacuum to grab that piece up and then emulsifying it. Every time I try to eat pieces and you get that sudden loss of resistance, you can see the whole lens is just jerking. Again, it's that sudden change in pressure that causes that to happen. Trying to loosen that last piece of the second quadrant up with the chopper, loosening it up, lifting it up, and trying to eat that piece, using vacuum as well as a chopper to fracture the lens piece, sandwiching it and crushing the pieces, and then emulsifying it. I don't want to spin that lens because of what I see here of the loose zonule. So I grab it with the vacuum with the phaco tip, and as I lift it up, I'm trying to separate the bag and the lens. So I'm able to lift the lens piece up, using the chopper to peel it and tease it from the capsular bag. Again, very loose, very unstable. You see that, again, sudden loss of resistance and the jerking of the capsular bag. Again, it's on low flow setting, so a little bit of collapse of the bag there. Again, trying to get that last quadrant out of the bag. It's a little bit in the subincisional area, teasing it up. Just a little bit more effort there. Using some vacuum, trying to tease the lens all the way out of the bag. So eating those fragments up. Separating the lens piece from the bag with the chopper, teasing it apart. And right here, I grabbed the peripheral capsule on the left side, and now it's completely gone. So again, using vacuum in this situation is really dicey, but of course I need that vacuum to take the lens piece out. So okay, I'm like, all right, now on the left side, the zonules are completely gone now. So I take the chopper out, but keep on infusion, keep that phaco tip in, keep infusion on the entire time, pushing dispersive viscoelastic over that defect of the zonular dehiscence on the left side, pushing some more viscoelastic in, and then trying to open up the bag here because of the collapse. making my paracentesis incisions now for the capsule retractor. So I'm making 2 incisions. And then the capsule retractor goes right in. When you push it, it just pops in. This is from MST. And then using a one-handed maneuver, I'm able to hook the rexus edge. Again, just pushing it, and it goes right in. And then using a one-handed maneuver, you can just pull it, and then it hooks the capsular bag with the retractor. So lift the incision with chopper, go in with irrigation off, and then turn on infusion. Obviously, there's a lot of viscoelastic now. That should give me some level of protection. Start to eat that piece. Grabbing it with some vacuum. Trying to carefully eat the rest of that endonucleus. So again, very unstable bag. Carefully eating the rest of that endonucleus that's left. Okay, now it's up. Just being very careful. Again, asking them to adjust the bottle height. And then I start to eat that last piece of endonucleus. And then now this is the epinucleus. Here I noticed that the retractor disengaged from the rexus edge here. So with the phaco tip still in the eye, I take the chopper out, and then while I have the phaco tip in the eye to keep the chamber, I'm using my left hand to try to hook the edge of the rexus here. You saw I turn on vacuum accidentally and it grabbed the bag. Didn't really want to do that. And then now I was able to engage the rexus edge here. So now that I have it, now I start to engage vacuum. So good. So I was able to eat most of the epinucleal material. You can see the bag is basically worthless. But at least I've engaged the edge of the rexus with the capsule retractor using two-handed technique. Again, hooking the rexus edge with that capsule retractor and simultaneously eating the epinucleal material. So I go back in. I probably should have gone with the eye and a handpiece at this point, but I went in with the phaco tip to eat the rest of this fine area of lens material, the cortex. And it really doesn't make any sense because when I do that, it just kind of goes into the entire port and the whole bag is going in. So I stop, I push dispersive viscoelastic to push everything back. Go ahead and close my main incision. And why? Because I'm going to convert to the Yamane technique. So I close my temporal incision and then rotate so I'm sitting supratemporal. I use the trocar. Again, I'm indenting with the trocar 3.5 millimeters posterior to the limbus. And I always like to stay just to the right side of my main incision. I tunnel tangentially about 3 millimeters and then I dive down. And when the trocar cannula sits sideways, it means I have a self-sealing incision. This is how you remove a capsule retractor. This is the easiest way I've discovered. Just take the stopper off and then just twist it 90 degrees, turn it 90 degrees, and when you turn it 90 degrees, you can pop it out. So super easy. Take the stopper off, rotate the capsule retractor 90 degrees, and you'll be able to take that inner part out. This is the simplest way and the most gentle way to take that thing out. Drying the surface of the eye with a Weck-Cel sponge. There's no vitreous so far in the anterior chamber or to the wounds. Inking the limbus on the right side and then the left side using the 27 gauge cannula that's inked at the tip. Using that same cannula to find 180 degrees apart on the left side. This is a fixed caliper from Epsilon. Again, I don't have any financial interests. I'm indenting 2.5 millimeters posterior to the limbal mark and then 2 millimeters adjacent. And when you indent with the caliper, you can see the small indentation marks. And then using that same cannula, I'm inking those indentations on the right side and then now on the left side. Again, you want to make sure it's nice and dry with the wax cell sponge. Again, indenting 2.5 millimeters posterior to the limbus and then 2 millimeters adjacent. You can see there's a little bit of ballooning of the conch here. So I'm trying to massage and compress and squeeze the conch down and then inking those indentations. These are my paracentesis incisions, the one in the upper right hand corners for my infusion, and then the one contra-incisional is for the externalizing of the leading haptic. This is some more dispersive viscoelastic filling the anterior chamber, and this is the 3 millimeter incision, again perpendicular to my limbal marks. This is a 22 gauge thin-walled AC maintainer. And then I'm going to perform anterior vitrectomy through the pars plana approach. But I'm being mindful not to eat the bag. I have not eaten the bag yet. Just do the vitrectomy. This is a 25 gauge needle. I'm bending it in such a way that the bevel is facing to the right, so I can externalize the leading haptic through a passive docking technique. This is the right side 30 gauge thin wall needle. I'm bending it 9 millimeters from the tip with the bevel facing towards me, towards the main incision. That's the right side needle. And this is the left side needle. I'm bending it with the bevel facing away from me at the hub. That's the cartridge for the AR40 lens, the emerald cartridge, pushing cohesive viscoelastic through the barrel and on the platform. And then placing the Sensor AR40 lens on the platform, pushing the optic down, making sure it's nice and seated, bending the wings so that the lens bends backwards, the trailing haptic goes out the back, and the leading haptic goes straight through the barrel. Sliding it into the injector, making sure the trailing haptic is up and outside of the barrel so it doesn't get damaged. Placing the 25 gauge needle through the contralateral limbal incision. As my assistant advances the AR40 lens, I'm having both bevels facing each other, and as the leading haptic comes out, I'm able to dock the haptic on the bevel of the needle. As she advances the lens, more and more of that haptic goes into the needle, and then I'm able to pull the needle out, and then that allows the haptic to come out passively, and then deliver the optic, sweeping the trailing haptic to the right. Pushing some more dispersive viscoelastic to push the lens back and protect the cornea. So I'm holding the trocar, staying nice and flat. I tunnel 2.5 millimeters posterior to the limbus, stabbing through the conjunctiva and sclera, and then staying nice and flat, tunneling 2 millimeters, and then diving down. Using my smooth micro forceps from MST, I do a sideways slide maneuver, placing the trailing haptic into the eye, dock the haptic on the bevel of the needle. 2 pushes and then I'm in. Disengaging the needle from the syringe. Laying it down. Using the smooth microforceps to pull the leading haptic into the angle. With counterforce, I'm holding my contralateral limbal incision. I'm turning the eye a little bit so that I can use the caliper one more time to measure, to make sure I'm 2.5 millimeters posterior to the limbus. Again, because the marks are distorted, I want to make sure, but I can see my indentation, so it's a little bit more peripheral than my ink mark. I stab the conjunctiva and sclera. I'm trying to get a little bit more leverage because the eye is kind of turning from me. The sclera is a little bit soft. But I go ahead and just grab the incision again. I felt like this gave me the best leverage. Staying nice and flat, I can feel the resistance of the needle going through the scleral tissue. I go 2 millimeters and then I dive down towards the nerve. Grasping the haptic as close I can to the tip. Docking the haptic on the bevel of the needle, and once I have it docked, I'm able to rotate the bevel. You saw my left hand, I'm rotating that needle, trying to find where I can dock it, get it nice and aligned and parallel. Sometimes you have to try again, so I disengage. And I was able to feed it in. So 2 pushes. Pull both needles out, and then pulling the left side needle all the way, but then limiting how much haptic comes out. Lifting the haptic up a little bit so it's out of the BSS, cauterizing the tip. You can see how flat the haptic is. That means I have a nice scleral support for the lens. Doing the same thing on the right side, pulling the needle out, but making sure I have my forceps ready to grasp the haptic as it comes out. Limiting how much of that haptic comes out of the eye. Lifting the haptic a little bit. Getting that AC maintainer out of the way as I do it. Cauterizing the tip. You can see how flat the haptics are. Again, the haptics are flat, which means I have a nice scleral support. This is the opposite of the flagpole sign. A flagpole sign would mean that you don't have good scleral support, and that means the optic would be sagging posteriorly. You'd have a bad refractive outcome in that situation. You can see a perfectly centered lens now. By having that nice flat architecture to the haptic, laying nice and flat to the sclera, you know you're going to have a good refractive result. Injecting some intracameral triamcinolone, performing some more pars plana vitrectomy. Again, no evidence for vitreous throughout the entire case. Go ahead and close my main incision with a 10-0 nylon suture. Go ahead and bury the knots. Take the trocar cannula out. Turn on infusion and make sure that I don't have any leaks. So no leaks. Great. Performing the surgical PI using the vitrector. This is the low flow setting. Taking the AC maintainer out, removing the viscoelastic from the anterior chamber, and then I'll hydrate my incisions. Okay, and so this is a case of, I thought, a routine cataract. It was far from routine. You saw multiple signs of zonulopathy. The left side, as I was pushing viscoelastic, the left side of the bag and the lens pushed back further. As I was doing the rhexis, you saw all the stria within the capsular bag. As I started to remove the lens, again, I did a terminal chop technique, which I think was a good idea to debulk the lens. In this case of zonulopathy, I was able to crack the lens and then perform a cross chop maneuver. Again, utilizing mechanical fracturing concepts to crush the lens, leveraging also vacuum whenever I needed it to get the lens piece up. But again, when I was trying to grab that last piece with high vacuum, it grabbed the edge of the capsular bag on the left side and it caused the zonular dehiscence to exacerbate. I used capsule retractors to retract the capsule to the periphery. And that does 2 things. It keeps it in correct anatomic orientation, but it also keeps the vitreous back. I was able to get the last piece of the endonucleus out, as well as the epinucleus. And then I took the retractors out, closed my incision, and then performed the Yamane technique, externalizing the leading haptic through a contralateral limbal incision with a 25 gauge needle passive docking technique. And then using this AR40 lens with 30 gauge thin wall needles. Again, nice flat approach because I stay nice and flat when I tunneled the needle through the sclera. And this patient did great. Post-op day 1, the vision was 20/40, uncorrected, and the patient continues to do very well. So I hope this was helpful to you, and I thank you for your attention.